involved with RSN for nearly 15 years. Support from someone who's been there makes all the difference.
Hey David, what are you listening to?
Kidney Talk, an online radio podcast that talks about kidney disease and the prevention of it.
Oh cool, where can I find that?
Oh, you can download it on iHeartRadio, Google Play, and Apple Podcasts.
Oh nice, I'll definitely have to download that.
Shout out to Renal Support Network, the annual Renal Support Network essay contest. I won the Renal Support Network contest last year, the Warrior, and we are all warriors. So thank you. Keep on doing all that you do, and be happy and healthy and keep the hope. Thank you, Renal Support Network. Woohoo!
As a kidney transplant recipient, I find that having an actual publication like Kidney Talk is an invaluable resource for any kidney warrior at any stage.
RSN keeps me informed of kidney advocacy issues so my voice can be heard.
I'm really looking forward to the prom this year and meeting people who are just like me. Dressing up is super fun and all the activities are amazing. Can't wait to see you there.
Hi, I've been participating in the Renal Support Network 30-minute fitness Zoom classes. Not only have I lost 15 pounds, but I can also strike a yoga pose like this.
When I created Renal Support Network back in 1993, I had no idea the impact that I would have among my peers. An illness is too demanding when you don't have hope, and peer support, education, and knowledge are crucial to our survival. We have a great week planned with some incredible speakers, great information for you to share, learn, so we can survive and thrive with this illness. It's imperative. So stay tuned. We're going to have a great event, and a shout out to our corporate mission partners for making this happen.
Now we are going to move to Dr. Geoffrey Block, and he is going to talk to us about something everyone with kidney disease can relate to at some point. Itching. He's going to talk about itching, and I believe how to stop itching, the effective means of stopping itching. But before I actually get to that, let me give you some of his creds, because we wouldn't want to forget that. So let's see. Dr. Block is, sorry, I had it, and then I lost it. Here we go. He's the Associate Chief Medical Director and Senior Vice President of Clinical Research and Medical Affairs at U.S. Renal Care. And also, he served as a Director of Clinical Research and a partner at Denver Nephrology. For the past 20 years, he's actually been involved in clinical trials, and we are very much looking forward to hearing him today. Again, if you have questions for Dr. Block, please put them in the Q&A section, and we will get to them at the end of his presentation. But again, if you can't find it, put them in the chat. And one more housekeeping thing, because I saw a lot of people come on after I gave my last announcement. If you want to win the raffle, stick around till the end for the raffle, but we need your full name. So if your Zoom screen name, or you're on your phone, so your name doesn't appear, or you just use your first name as your Zoom screen name, please put your name in the chat so we can enter you in the raffle. And now, take it away, Dr. Block.
Thank you very much. I'm thrilled to be here, and thank you for the introduction. And Tim, I have to tell you, I live in Denver. I live in Golden, Colorado, so I'm pleased to hear at least part of your journey has been through our city. And I actually want to comment, the second part of my conversation today is going to address one of the things you said, which is this problem of vascular calcification in patients who are on dialysis, and particularly long-term dialysis. But anyway, Lori, I want to thank you personally for giving me the chance to speak. I am a a nephrologist first and foremost, and I've been taking care of patients for the last 23 years, and that is an incredible privilege. And over the course of my career, I've gotten to know Lori in a number of capacities over the last 20 years, and can't say enough about how important the work that she and her team has done to help provide hope and guidance and support for all of our patients who are going through this. I heard before I jumped on, I love the comment about optimism. You can't see the rest of my shirt, but it says powered by optimism, which is what we all every single day, getting us out of bed to do what we do and make a difference in the world. I couldn't believe it more strongly. Let me, can all of you see my screen? Let me just, one over here with the slide on it.
Yes, we can.
Okay, awesome. Thank you, Lori. So I'm going to talk today about itching, as you heard, and I'm going to go through a couple of things about sort of, what it is and how common it is, and then talk a little bit about therapy and why it happens and what we can do about it. And then for those of you who know me, everything in the world is about phosphate. So I'm going to end up making this mostly about phosphate on the second part of this conversation, because phosphate is the answer, as my children know, to every question that we have. So phosphate and mitochondria.
Dr. Block, can you start your slideshow? Because we can see the sidebar. So can you go to slideshow and put play from start?
Yeah, I can, but honestly, it doesn't matter to me if you see this slide. Let me try and find Lori the.
Don't worry about it. If we're fine, if you're fine.
That might change the share. Did it? Can you still see the slide?
Yes, it's actually bigger now.
All right. So let me get started. So first off, you might hear about this referred to as uremic pruritus, right? And uremia is just a term that doesn't really roll off the tongue, and something that we probably should try to move away from. It's so nonspecific, and people have this thought that it only applies to those with really advanced kidney disease or even on dialysis. And so I think the term that many people now use is CKD-associated pruritus. And so I'm going to use that term throughout the presentation. I failed to mention, by the way, that the first part of these slides came from a presentation done by a few other docs a few years ago, a year and a half ago, that I participated in and helped design. So you'll see some of these slides are sort of branded in that capacity. I guess I should, for disclosure purposes, also tell you that I am on the board of directors for a company called Ardelyx, and I've taken a few slides that relate to phosphate management from one of those slide decks. So please keep that in mind. I think most of you know I've spent my career studying phosphate. So CKD-associated pruritus is really defined as any itching that is in individuals with kidney disease that doesn't have another obvious comorbid condition to explain why that itching happens. And I think it is important to remember there are some other things that can cause itching in kidney disease, and particularly if someone's been on dialysis for some time and then develops itching, I think that it would be important to make sure that there aren't associated other illnesses that might account for the itch. I mean, those can be related to new medications. It can be a manifestation of an allergic reaction to a particular medicine. It could be things related to diverse things like hepatitis or viral-induced liver disease, and then a few other things that are a little more serious. So most itching that occurs in people with advanced kidney disease, we attribute to this CKD-associated pruritus. It is unquestionably under-recognized. And unfortunately, as many of you on the call may know, that symptoms can last really for a very, very long time. And thankfully, they can be intermittent, but they are very long-lived. This is a really common problem. And as I alluded to, it's not just dialysis patients, right? There's only been a handful of really good studies on uremic or CKD-associated pruritus. But from those observations, we see that about a quarter of people with CKD not on dialysis complain of some degree of itching. And I'll show you, probably 60 or 70% of people on dialysis complain of itching as a symptom that is associated with substantial effect on quality of life. So this is really, really common problem, which doesn't get a lot of verbal attention or even sort of intervention because of limitations that we'll discuss. And it's not a U.S. problem. Let me just share with you. I think that DOPS, I know all of you are familiar with DOPS. DOPS is a wonderful, very, very long-term practice pattern study. And you can see now this is spanning the last, 30 years, 25 years of DOPS data, that this is a common problem throughout the entire world in people on dialysis. So it's remarkably constant, the proportion of individuals who complain of moderate or severe. So this is moderate or severe itching in dialysis patients. So 40 to 50% of people around the world on dialysis have moderate to severe itching. And when you sort of drill down a little more deeply onto this, and you look at this goes through, DOPS has gone through several phases based on the year that it was rolled out. They're now on beyond phase 5, but you look at, again, it's remarkably consistent. This is across the entire time frame. How many people have extreme itching who are on dialysis? So 7 to 12%, and maybe it's gone down a little bit if you're an optimist over the more recent time frame, but honestly, it's not discernibly better. And if you look at those people who, as I said, moderate to severe itching or moderately bothered or extremely bothered, you're talking about 40% of individuals in the modern era who have real problem with itching. Now, one of the sort of interesting conundrums that all of you are probably aware of is that if you try to figure out who's actually itching, that patients don't talk about this very much with their providers. And when they do talk about it with their providers, it's usually the nurses or other healthcare providers that take care of them on the team, the PCPs, the patient care techs or the nurses, and then come their primary care providers. But you see that the one that's highlighted there, that a third of the time they don't tell anyone. And only a quarter of the time do they tell their nephrologist. And that's likely because of what we'll get to in just a few slides, which is the limited therapeutic options that we have currently to give people for their itching. So it's a big problem. It's moderate or severe, affects 40% of people, and yet very few people, certainly less than half of people, actually talk to anyone about their itching. And that's a bit of a problem, right? Because this is important for a number of reasons, that not the least of which are what it does to people's actual skin. And I'm going to show you some images here, but itching is not just a sort of a symptomatic problem. It is a physical problem, and it can lead to some severe complications because of the itching. I think that all of you probably are aware, the scratching that goes along with itching can cause both acute and chronic changes in the skin, and I'll show you some examples of that. But over time, those changes can become really difficult to reverse. And then there are, of course, the real problem of superimposed infections when you consistently disrupt the skin barrier. And many of our patients are infected with MRSA. And MRSA is just one of the bacteria that, are potentially involved in the problems here. It just happens to be a particularly challenging one to deal with, but it's not just methicillin-resistant Staph aureus that we're concerned about. We're concerned about strep, we're concerned about Staph aureus in general, and other typically gram-positive infections that result from this access of bacteria into the bloodstream, and even more so in people with vascular access. So many times people can scratch the skin overlying their access, which results in a real tremendous problem. And those with catheters, which we continue to struggle in this country with the catheter problem in people on dialysis. But introducing bacteria into the bloodstream in people with catheters is a potentially life-threatening complication of this symptomatic problem. So I'll show you, this is probably pretty familiar to most of you. This is what, the excoriations that we see when you examine people on dialysis. If you look for, manifestations of itching, you can see these sort of not uncommonly. When they become a bit more chronic, you get these sorts of lesions where you can see not only do you have the crusting and the scabbing that occurs on the lesion, you begin to see this nodular appearance to the skin underneath, which suggests the chronicity and the scar formation that's happening under the surface of the lesion. And then Of course, these can cause deep scarring. You can see, you look at this person's back and you can see, this is something that's been going on now for obviously a very long time. So there's acute and chronic changes of the skin with nodules and pigmentation changes and really tremendous problems. And you can see all of these would be associated with an impact on not just their quality of life, but their risk of infection. One of the things I had the privilege of participating in a few clinical trials related to itching, and one of them related to trying to have patients describe where the itching is occurring. And this is one of the figures that really stood out to me from our publication, which is we had people sort of mark on a piece of paper where they itched. And what you see here is that, first off, it can go anywhere from localized, to essentially the whole body. But the striking thing is the symmetry of the itching, right? So you can see that in almost every image, and this is a handful of examples, in almost every one of these, you see that there is this symmetry on both sides of the body with regard to where the itching is happening, right? And it's remarkable, and it suggests one of the things we'll talk about, which is what's causing the itching, which is not just local skin problems. It's clearly related to the nervous system, and I'll show you probably more than the nervous system, the immune system. So the symmetry of the itch suggests some of the underlying pathophysiology that's happening. Now, importantly, outcomes associated with CKD-associated itching are real, right? And one of the really important outcomes is the effect it has on individuals' quality of life. And I think that, I don't have to tell all of you that the quality of life measurements in people on dialysis are often worse than people with many other chronic illnesses, including those listed on the slide here. And itching severity is absolutely and unequivocally related to quality of life. So I think there's a movement among the research field and in general, thankfully, to not just standardize outcomes in nephrology and the work of what we call the SONG initiative, but to standardize outcomes that matter to patients, right? Instead of talking about what we're doing to lab variables and what we're doing to, things that don't affect people's lives, I think most of us realize we have to start looking at measures that affect people's lives, and this is one of them. There are a number of other things, believe it or not, beyond quality of life that are associated with CKD-associated itching, and those include really clear impact on sleep quality and sleep disturbances. There's the psychosocial effect of being embarrassed about having these excoriations or chronic issues with skin and the appearance that it causes on the skin. It can absolutely result in a worsening of depression, and probably for all of these reasons has been associated in even adjusted analyses with mortality risk. There's no question that it affects potential use of other medications, including ESA, iron, and the need for IV antibiotics. And I think, unfortunately, also is associated with missing dialysis treatments. And we'll come back to this effect of dialysis in just a few minutes. So if you think about what are we doing for this, right? If it has this really a profound effect, if it's very common and very severe and profound effect on things that matter to patients, you have to ask yourself, well, what are we doing for it today, right? And even when you look at people who have moderate or severe itching and are nearly always bothered by it, they don't talk to their kidney doctor very commonly. In fact, you can see there, when people do get therapy, they rarely get it from their kidney doctor, and they turn to other providers if they turn to them at all, to try to get some therapy for this. And when you look at what they do receive, again, this is specifically looking at people who complain of always itching, right, or nearly always itching. 30% of them don't get anything at all for their itch, at all. So they're just left to essentially suffer this problem without any intervention. The most common therapy people get are these over-the-counter topical creams, and those do have a role in terms of emollients that can help improve the hydration of skin, because dry skin is very, very common, and dry skin leads to itching. And so topical emollients are, in fact, one of the very, initial conservative things we can do for your CKD-associated itching, but it's certainly not where the story should end. And we certainly shouldn't be in a position where 30% of our patients don't get anything. There are topical medicines that can be applied with some efficacy. There are some topical creams which combine a very low dose of a steroid, which has an anti-itching effect, and a topical anesthetic that can have, again, because this is related to the nervous system, as we'll talk about, can have some effect on itching. And then if it's very, very localized, which is uncommon, there are some creams which can are very specific for anesthesia, things like capsaicin, but are uncommonly used and don't work all that well, mostly because the itching tends to be very symmetric and more than just local. The oral medicines that get prescribed and the over-the-counter medicines that get prescribed are pretty rare, and I'm not a big fan. We'll talk about that in just a minute. Most of the time people get prescribed antihistamines, right? And antihistamines in general don't work. Let me just tell you that. I think that they are the most common drug that people tell patients to take for the CKD-associated itching, and they really are not effective. They don't address the underlying physiology, and they don't actually address the symptom related to why people itch. And they have a tremendous number of side effects, and I am absolutely not a big fan. Let me talk a little bit about why people get this, right? Why do people with kidney disease itch? And I think we don't have a precise answer, but we're getting a little closer. And there's no question that there are, as I showed you, there's absolutely absolute certainty, I think, that there is something to do with the peripheral nervous system, and both nerve conduction studies and the symmetric distribution of this itching suggests that it's a peripheral nerve issue, and that underlies some of the therapy that we can give. And we'll talk about that again in probably the next slide. The second thing is that there's no question it's related to the immune system in some way. And so there's a pro-inflammatory state even among dialysis patients when you look at those who itch versus those who don't itch. So we all know that inflammation is common in people on dialysis or with advanced kidney disease, but specifically those inflammatory mediators are even higher in people who itch as compared to people who don't itch. So there's no question there's some component of an immune system abnormality. I think encouragingly, we're now understanding that there is likely to be some dysregulation of the opioid system. And the next few slides after this, I'll talk about why that might be important. But there seems to be an imbalance between kappa opioid receptor agonism and mu opioid receptor agonism. And while I don't want to get into too many details, this is a real opportunity moving forward for how we might intervene. And then the second part, I'm going to talk about some of these things that you're well aware of, or people at least refer to, which are abnormalities specifically related to kidney disease that include changes in calcium and phosphorus and PTH, changes in the skin that result in dehydration, like atrophy of sweat glands, and abnormality of mast cells. So all of these things together likely explain why 70% of people itch with kidney disease and why some people itch really severely with kidney disease. And this is the slide that should underlie how we approach the management of this disease. So there's a need for better therapy. Let me be clear about that. There is a need for better therapy. The current standard of care is inadequate for taking care of this problem, given the burden that it creates for individuals. So we're going to talk a bit about some of these. I'm going to talk about calcium and phosphate in more length here in just a few minutes, but clearly getting adequate dialysis or even more than minimal threshold. I'm not a fan of the term adequate dialysis. All right. The adequacy targets establish a bare minimum below which we should never go, but they don't define optimal. And I think there's no question that optimal dialysis is more than the bare minimum. And time on dialysis and getting good dialysis is actually been shown in some anecdotal studies to improve itching. When you go to a KTOV of 1.5 or 1.6, you can improve symptomatic itching. Topical emollients to moisturize the skin are in fact important and a conservative first-line therapy. As I said, I'm not a fan of antihistamine. Many people receive gabapentin or pregabalin as a therapy for this, and they likely have an effect because of their effect on the peripheral nervous system. So I think that given prescribed at the right dose, both gabapentin and pregabalin are reasonable courses of therapy for people who have persistent itching. And then some of you may be aware we can use what's called UV phototherapy prescribed by the dermatologist to help alter some of the responsiveness of the cells in the skin to stimuli that reduces itch over time. But this is a course of therapy that takes an extended treatment regimen. So it's very, very short, but you have to go a lot of times to the dermatologist to get this over and over and over again to have it be effective. So the bottom line is, if people get anything today, they tend to get antihistamines and maybe some topical emollients, and that's really about it. And, you know, that's not where we should be. There is nothing approved by the FDA to treat CKD-associated itching. And I want to spend just 2 minutes on this, on the future where I hope we are, which is this kappa opioid receptor agonist, which is called difelikefalin. Some of you may be aware of it, and it's the research for this in dialysis patients has been finalized, and I believe they're going to be submitting to the FDA if they haven't already. I'm not associated with the company that does this, but this is a kappa opioid agonist that clearly modulates itch. It has some effect on pain and inflammation, and one of the benefits is that unlike other kappa opioid agonists, it is restricted to the peripheral nervous system and really selective for the kappa opioid receptors. And I'm not trying to get into too much science, so please forgive me, but I just want you to know that, let me just show you why this therapy, when it becomes available, has some interest to all of us. The itching pathway starts at the skin, okay, and the cells in the skin that react to some stimuli, whether that's the nerve cells in the skin or the mast cells in the skin or the immune cells in the skin, they react to a stimuli that then cause the peripheral nerve to sense itching, either directly from the nerve terminal or through this inflammatory mediated response. And so what you see is that either coming from the nerve itself or from the skin and immune cells, this signal reaches the spinal cord, and from the spinal cord goes to the brain, and essentially you perceive itch. All right. Now, sometimes itch is perceived as pain, and sometimes pain is perceived as itch because of this sort of overlap between this signaling process. The kind of cool thing about difelikefalin is that it affects the opioid receptors in the peripheral nervous system, right? It has some effect on the inflammatory markers themselves because those cells respond to nervous stimuli, but primarily it affects the sensory nerves, and it produces this anti-pain, anti-itch effect by turning on kappa opioid receptors. But the nice part is it does not cross the blood-brain barrier. So it doesn't get into the spinal cord, and it doesn't get into the brain. And it's the opioid receptors in the brain where we worry about things like this dysphoria or altered level of alertness or hallucinations and those things that, you know, we're all afraid about opioids. So difelikefalin, one of its unique things is it addresses some of the basic physiology of of itch, but it doesn't get into the blood-brain barrier. I just want to show you a couple of things, because I'm guessing I'm going to run out of time here, but about how this was assessed in clinical trials. And it was asking people to rate their itching on this scale of no itching, 0, to worst itching imaginable on this numeric rating scale, which was 10. And the second way they did it was using this quality of life measurement tool, where they asked people to evaluate itch as it related to their disease, their emotional distress, and their social functioning. And I won't go through all of these, but just to point out that the higher the number, the more affected people were in using this particular index. And so if you look at what happened with the placebo-controlled trials of difelikefalin, you can see that when you compare individuals, if I can find my cursor, which I don't seem to be able to do. Isn't that funny how that happens? Sometimes your mouse just decides like it is not going to be available. So there we go. So you can see with difelikefalin, this is this bar here, that over the course of 8 weeks, the numeric rating scale went from really 7 out of 10 down to mild symptoms at 3.5 out of 10. Now there was a placebo effect, not surprisingly, but there was a big difference between the placebo-treated patients and the difelikefalin-treated patients. And the nice part is that over the course of just 1 month of getting this medicine, people really moved from severe itching down to mild itching with the medicine. And by the way, it's given on dialysis. At the quality of life measurement tool, you saw very similar results that over the course of 8 weeks, those people who got difelikefalin had this really substantive improvement in their quality of life associated measures over time. So I think that there is some optimism for where we are going to be able to move this really meaningful problem in the future. And this is just to show you that even the sleep disturbance got better in people over the short term in people treated with difelikefalin, at least at the lowest 2 doses compared to the placebo-treated patients. So I think really optimistic, I guess, coming back to the optimism theme with where we're going to be in the future with how we can make people feel better. Now, if you would be so gracious, Lori, do I still have a few minutes to talk about my favorite topic, which is phosphate?
Yes, you have until 11:15.
Yay. All right. So I want to talk about some misconceptions, if I could, about phosphate, if you don't mind. And you see this slide is an Ardelyx slide. I apologize. I hope you don't perceive an industry bias. My life has been spent in this area. And it's nice to have some innovation. But let me talk for a minute about what I think are some really common misconceptions. And in fact, I don't want to make anybody mad, but even in the Kidney Life magazine that was just published that talked about itching, there are some things that I'd like to sort of reshape with regard to how we view phosphate, and not just its role in itching, but where it fits into a patient's experience and how we should be thinking about this. So first off, I think that while people think we understand phosphate physiology, we don't truly understand phosphate physiology, all right? Everyone says that people eat about 1,200 milligram per day of phosphate. Let me just tell you that data comes from nutritional databases that almost everybody who spends their time in this field acknowledge are off by between 50 and 100%. All right. So while we think people are taking in between 800 and 1,200 milligrams a day, they're likely taking in between 1,200 and 2,000 milligrams a day of phosphate. And this is a public health issue because no one has to tell you how much phosphate is in the food that you eat. And that is, in my opinion, ridiculous. So please recognize that patients are not to blame with regard to when their phosphate is high. It's not because they're not following our advice, and it's not because they're not doing what we ask them to do. And I get really frustrated with doctors and dietitians and nurses and others in the industry blaming patients for a high phosphate. That is ridiculous. Nobody knows how much phosphate they're eating. And I'll show you, nobody understands really the reasons why phosphate is so difficult to control. But please remember that we're probably underestimating intake by a huge amount. Regardless, one of the things that people should know is that humans are primed to absorb most of the phosphate we eat. And that's because phosphate is critical to life, okay? There's only 4 elements that have been described that no living organism can do without: carbon, nitrogen, oxygen, and phosphate, okay? Nothing lives without phosphate. So we are primed to absorb most of the phosphate we eat. And as a result, we absorb about 70% in aggregate of what we take in. And it goes in the bloodstream, and then it goes elsewhere, okay? And people forget about this point, right? It doesn't just stay in the bloodstream or go out in the kidney. it goes back and forth in cells. And honestly, that regulation of moving back and forth, not just bone as shown on this slide, but moving back and forth probably in muscle is unbelievably complicated, and we don't understand it all that well. All right. But it is not simply what you eat is what's in your blood. Okay. That is not the way this works. Now, what does matter is how much kidney function you have and whether or not you can get rid of the daily amount of absorbed phosphate or not. And obviously, if you don't have kidney function, you can't do that. One of the barriers we face systemically, and I'm working to change within our U.S. renal care organization, is this misconception that we're treating silos of illness. We're treating phosphate, or we're treating secondary hyperparathyroidism, or we're treating renal osteodystrophy. That's nonsense. What we're treating is this problem called MBD, which is what's happening to people like Tim, right, who can't get a third transplant because he's calcified his artery, all right? That is a manifestation of MBD. That's not a problem with PTH. That's not a problem with phosphate. That's a problem with the whole thing. And we have to think about it as a systemic disorder, and we have to treat it as a systemic disorder and stop talking about that we're doing that and actually start doing that in practice, and stop focusing on PTH as the metric by which we assess whether or not our patients are getting good care. And you'll see that's where I'm taking at least our organization. Let me just walk through one of the problems with as you lose kidney function, of course, is that what you absorb stays about the same, but what you get rid of doesn't. And the two hormones that primarily affect trying to get rid of phosphate are hormones called PTH and FGF23. FGF23 is not measured by your docs or your dialysis units right now, but that doesn't mean it's not important. And we're learning that it is actually a really important hormone. It goes up very early in the course of kidney disease, and it's a signal to help your body try to get rid of phosphate. These two things both tell the kidney to get rid of phosphate. So they have good intentions, right? The problem is that those good intentions become negative consequences when your kidney doesn't work well enough to respond to them, all right? And hi, Dinesh. I see you're staring at me. I hope you just showed up on my screen. So the problem is that the negative consequences that happen when your kidney can no longer respond to these signals are significant. So you end up in a situation where while you initially can compensate, that ultimately fails and blood phosphate levels go up. And more importantly, phosphate balance becomes out of balance and you start retaining phosphate, whether or not your blood phosphate goes up or not. And now it comes at the expense of really high PTH and really high FGF23. And I just want to tell you that both of those things, the phosphate and the FGF23 itself, both produce side effects in terms of why our patients experience cardiovascular events. And I'm not going to go through these in detail, but I'll just share with you. They produce complementary bad things, okay, that affect the vasculature in terms of calcification, and then the heart in terms of how it responds, or the structure of the heart, how it can respond to those altered blood vessels. And you add all that together, and then you do dialysis, and you have a recipe for why we have a problem with cardiovascular disease related to MBD. Let me share with you that some sort of, I apologize for the sort of cartoon here, but it's useful. People don't really pay much attention that we absorb phosphate in a couple different ways. One is through this direct, really wish I had, there we go, mouse, this direct pathway, which is through this transporter you don't need to worry about, but it goes through the cell. This is important when you don't have a lot of phosphate in your diet, okay? So in a human being, if you were in a situation where you didn't eat a lot of food that had phosphate, you would want to absorb almost all of it, and you would make sure that you're actively absorbing all the phosphate you can. That's what this pathway is for, this active phosphate transport through the cell. As I told you, the problem with us is not having enough phosphate in our diet. We have way too much phosphate in our diet, okay? So that pathway, this one, is of almost no relevance to us because we saturate it at really low levels of phosphate in the diet. It's doing everything it can, okay? Where most of the phosphate gets into us is through between the cells, this way. And the problem here is that this is unlimited amount. The more you have there, the more you're going to drive between those cells, okay? And this is one of the problems with the therapy, phosphate binders, right? They don't affect, honestly, either of these pathways of absorption directly. All they do is, if you happen to time them correctly, every time you eat, they mix up with phosphate that gets liberated from your food, and you just sort of hope that it's like making I'll think of it like, do all of you eat these like protein shakes, right? When you put the powder in the cup and then you add some water and you shake it up, right? Okay, some of the powder gets mixed up, but a lot of the powder doesn't, okay? That's why we use phosphate binders. For the last 30 years, that's the only approach we've ever taken to trying to reduce phosphate, is basically shake it up in the stomach and small intestine and hope that it sticks together. And that doesn't address the real issue of how phosphate's getting absorbed. So, one of the things that I'm excited about is the future of being able to change that. I have this slide on here. Let me advance for a second, because I want to mention something. We tell all of our patients with kidney disease to eat less phosphate. That's very hard to do. They do a good job with that, and so they excrete less, and then the less gets in their body to deal with. But there's a misconception. Let me just tell you, and there's even one in that article that says that dialysis is not good at getting rid of phosphate. That's not true. All right, that's not true at all. Dialysis is really good at getting rid of phosphate. In fact, in the first 2 hours of dialysis, you get rid of almost all of the available phosphate you can from your bloodstream. Remember, we only get rid of poison from the bloodstream, right? So, and your phosphate gets so low during 2 hours of dialysis that there's almost nothing left to transfer anymore in the last 2 hours. And in fact, your body starts reacting to this and saying, holy cow, I don't have enough phosphate in my blood, and starts moving phosphate back into the bloodstream while dialysis is occurring, because we've lowered the phosphate level so dramatically, so quickly. The problem is we only do dialysis 3 times per week, all right? That's the problem. It's not enough to accomplish the week's goal, but in and of itself, it's pretty darn good. Let me talk about one other thing that I'm going to run out of time, Lori, and gosh, I'm sorry about that. I've done my best to try to pace myself, but we need to do a better job of educating everyone that just because there's phosphate in a food doesn't mean that has the same effect on whether or not we should eat it, meaning the bioavailability of the phosphate matters. And this is something that people don't give enough attention to. So we've told people to avoid nuts and avoid legumes and avoid beans, right? Because they're high in phosphate. Well, we don't do a very good job of absorbing the phosphate from that plant-based protein. And in fact, plant-based protein is an outstanding source of protein for people with kidney disease. So even though the estimated phosphate content is high, the actual effect on phosphate absorption is quite low. And we only absorb about 40% of this phosphate, okay? And then you compare that to basically anything you buy in a grocery store that's processed, anything, in which we absorb essentially 100% of that phosphate. And then you can see as you move up this chain, we do a really good job absorbing phosphate from animal meat, and we do a really poor job of absorbing phosphate from plant food, and we absorb 100% of the phosphate they add to our diet, and they add it to everything. So while I hear over and over and over again, patients get told, don't drink dark soda, and don't, okay, the problem is not dark soda, okay? The problem is not the 40 milligrams of phosphate in the dark soda. The problem is that we should be telling our patients to try to eat real food as best they can within their affordability, to avoid processed foods, all right, and to try and get phosphate protein from plants, because this is a really great source of protein. I'm going to skip this for the sake of time. I'll just remind everyone that this is not just a problem for people with kidney disease. There's abundant data, as you see on this graph, in people with normal renal function, that your blood phosphate level is associated with cardiovascular events, even in the range of normal. So we now understand that that higher phosphate levels for everyone are a negative consequence, and we don't understand why exactly, but we understand that to be the case. We don't know whether reducing it matters yet, but we do know that this relationship is really solid, even in early stage kidney disease. And then I do want to spend a moment on one thing near and dear to my heart, which is this MBD concept, if I could, in the last few minutes. And I hate to show a slide that talks about mortality. I worried about this, but it is something I have to be transparent about. We are talking about really, really meaningful things, okay? And that's why I'm so passionate about this and changing the way we treat. I think that we need to stop as a industry sort of pretending that this isn't a really big issue. As you can see from this analysis, this is just one of many, but this construct that no matter what your phosphate level, people do worse. People don't live as long the higher their calcium, regardless. And the opposite is true as well. No matter what your calcium, people live longer with a lower phosphate until you get below normal, okay? So if you ignore the below normal, which happens incredibly uncommonly, this is where we need to be. But 5.5 is not the number. And I saw that in the article. I want to sort of make this clear. 5.5 is not the number we need to be striving for. 4.5 is the number we need to be striving for. Now, we haven't done that because the phosphate binders can't get you there, and we don't give enough dialysis to achieve 4.5, but that's where we should be striving. And I'm going to skip this to get to one other slide here, which is this paper just came out, and it looked at what's the relationship between the time spent above 4.5, the time and extent above 4.5, and related it to cardiovascular events. And I just want to show you this curve, right? The time spent for dialysis patient above normal matters. This is what we need to change. We need to get phosphate normal in people on dialysis, all right? And I'm going to end for the sake of time and just tell you that I had the privilege of serving on 2 KDIGO committees addressing this topic. And while everybody gets mad at us for suggesting that we should try to have normal phosphate levels, okay, because they say it's not achievable, that doesn't mean it's not the right thing to do. And we have to stop pretending that all therapies are the same. And that's one of the things with this MBD concept. It matters how you get a normal phosphate. Aluminum, which Tim probably took when he was early in the course of his disease to lower his phosphate, turns out was not a great choice. Calcium to lower your phosphate is not a great choice, all right? And because of what it does to raising FGF23 and the effect on serum calcium and other calcium balance. So the bottom line is we can be better, we can affect people's lives, and we can affect the itching, which is where I should have been talking about this whole time. But I'm excited about what our future holds. I'm optimistic about being able to make people's lives better for itching, and I'm optimistic about being able to make people's lives better with regard to how we manage phosphate and MBD. So let me stop there for the sake of time, and hope you guys found that to be worthwhile.
Thank you so much, Dr. Block. I can only speak for myself, but for me, that was an amazing deconstruction of the complexity of phosphorus, for one. I'm 3 years post, and I just learned some things that I was not aware of. So I personally, and I think other people did too, because there was a lot of agreement in the chat, appreciate that breakdown for us. I do have now, we only have a few minutes, but I'm going to take, there are questions in the Q&A, there are questions in the chat, but I'm going to take just a couple questions if you don't mind, and have you answer them. So there are some questions about itching. There are a lot of questions about itching, but we'll take one basic one. I don't know if some of these were actually answered as you went through your presentation, but there's one about what do you recommend for head itch, shampoos, facial lotion. Somebody said her husband has a lot of itching on his arms and legs, and they bought Caladril and it worked, but according to your presentation, you're not a big fan of the OTC topicals. So did you want to address that quickly?
Yeah, I think that, to be honest, if it's working, that's what matters. All right. So I think that if Caladril is helping with the itch, that there's not a particular reason to stop. There are some people who benefit from antihistamines, and there are definitely some people who benefit from topical therapies. So don't stop just because of what I said. If it's working, that's fantastic. So this pathophysiology is complicated, right? And the issue is that not every person will have the same things causing their itch in sort of relative perspective. So for some people, maybe it's the nervous system which is driving their itch, and things like antihistamines aren't going to be very effective. They're sedating and they have, some other effects. But for some, it might actually be the histamine released from mast cells in their skin, which is driving their symptoms. And for those people, it might be the topical Benadryl or even oral Benadryl might work. So that seems reasonable. Head itch, honestly, I only comment, and I'm not an expert on this, but head is one of those places that's a little unusual to be CKD-associated itching in terms of symmetry, et cetera. So I would just recommend just making sure that there's not some other reason for the head itch beyond just CKD-associated itching, because that's a little bit outside of my experience as to where we see this.
So as far as there's a question about prescription topical, if someone was to go to their doctor and say, what about this? What would you prescribe? What would be one that you would suggest?
Yeah, so the only thing that's really been studied is this combination of steroid and anesthetic called Pramoxine, and actually I think it's over the counter now, and doesn't have to be prescribed. So prescription drugs tend to be the oral drugs that are gabapentin or pregabalin for the itching. And those, as you know, have to be dose reduced for people with kidney disease. So that's definitely something that needs to be done in concert with a physician or physician extender. So the prescriptions tend to be oral. The non-prescriptions tend to be topical in this regard.
Okay. Someone actually asked about clinical trials. Do you know of any clinical trials? I believe she said she was in Arizona, going on anywhere in the country.
Yes and no. So there are some finishing with the difelikefalin in dialysis patients, but I also know they are starting clinical trials in people not on dialysis with an oral version of difelikefalin. I don't think they've started yet. That company's name, by the way, is Cara. Again, I don't have a relationship with Cara, but they are going to be starting trials in non-dialysis patients with itching, I believe, within the next few months.
Okay. And last question are there any studies being done as to whether candida overgrowth might cause some itching in patients from immunosuppressive drugs like prednisone?
There's no question that Candida can cause itching, right? So if you get Candida superinfection after being on a course of antibiotics, there's no question it can be associated with itching. I wouldn't consider that to be itching, what we talked about, CKD-associated itching, right? So Candida infections can cause local itching for sure, but not the sort of systemic itching issue that we've been discussing.
Okay. Thank you so much for your information and your time today. We appreciate it very much. People are asking for your information, if they could get in touch with you, if that's okay, if you could throw that in the chat.
Sasha, they can send us the email questions and we'll forward them.
Okay.
Hey guys,
okay, great.
Thank you for inviting me, and thanks for everything you're doing, all of you. So have a wonderful day.
Thank you. You as well.
And a shout out to our corporate mission partners for making this happen.